I'm Dr. Rosalind Austin, and welcome to Researcher Revealed Season 2. This is the podcast where we go behind the title or the subject that's in a paper and get to know those authors who write the research, find out a little bit more about their research journey and why they're researching that area that they're researching. On today's podcast, we have a PhD student, and she's going to share. I'm not allowed to call it a masterclass because she says she's not an expert yet. She's going to share her experiences around her data collection for her PhD, focused on this specific type of method that she used, being focused ethnography. So a real deep dive into what that is and how to go about doing that type of research. I hope you enjoy. Hello, and welcome to the next episode in Season 2 of Researcher Revealed. On today's episode, we have the lovely Hilary Lewis with us. Hilary, can you introduce yourself? Tell us where you're from, what sort of professional background you have?
Hi, Rosalind, and hi, everyone. I'm Hilary. By background, I'm an occupational therapist who then went on to train as a psychotherapist. And more recently, I'm a PhD student at the University of Leeds with a fellowship from the National Institute of Health and Care Research.
Excellent. Thank you, Hilary. So let me get this straight. You're two things. You're both an occupational therapist and a psychotherapist.
Yeah, that's right. So I worked in mental health for a long time as an occupational therapist, and then just became a lot more interested in psychological therapy. I did a master's degree in cognitive behavioral therapy. So I see myself as both. At the
Wow,
moment.
that's very cool. Excellent. Thank you so much for that. Into your PhD, how far are we into it?
I'm a third of the way through. I'm slightly
Third of the way.
part-time, so yeah,
Okay,
15
third of the
months
way,
in.
part-time.
Yeah.
All right, cool. All right, so everybody out there, you know what comes next. It's time for our Researcher Revealed Rapid 11. So, Hilary, are you ready?
Let's do it.
All right. Are you a Windows or a Mac?
Oh, Windows.
Nice. Tea or coffee?
Oh, tea. Yorkshire tea. Always Yorkshire tea up in Leeds.
Ooh, nice, nice. When you're writing, music or silence?
It's got to be silent. I'm so easily distractible.
Oh, nice. See, I'm the opposite. Like, I have to have music because I'm easily distractible, because then any tiny little noise, I'm like, ooh, what's that? I must go check it out. That's really cool. Where do you tend to work? At home or in an office?
I'm kind of experimenting a bit. I think mainly at home, but then one thing I found now a year in is that I'm used to working in a busy hospital with a big team, and I'm starting to miss that now. So bit of half and half.
Nice. So hybrid. I like that.
Yeah.
What time of the day are you most productive, do you feel?
Probably I think morning.
Okay.
I've got a family, so I'm not going to be working in the evenings if I can help it. So I get as much done as I can before 5 o'clock.
Nice. Love it. When it comes to a referencing management system, which would be your favorite or which is the one that you use?
Yeah, I've not tried them all, so I couldn't say I've got a favourite, but I use EndNote because it was introduced to me and I like it.
Yeah, it does the trick, doesn't
It
it?
does the job.
Now, you might be too early for this question, but I'm still going to ask it. Is what about making graphs, figures, data visualization?
Mm-hmm.
What do you use to do that?
So yeah, probably a bit early, and I've not got the results to start thinking about how I'm going to display them yet. But I discovered Miro recently as a way of kind of playing around
How
with
do you spell
ideas.
that?
That's Miro.
Miro.
Yeah.
Okay.
So it's an online tool where you can play about with kind of virtual post-it notes, and other people, if you've got someone who's in a different place, can log into the same board, and you can move around post-its together and decide
So
how you're going to structure things.
more like a mind mapping thing rather than like a graph.
Yeah, not at graph
Nice.
stage yet.
Nice, I like it. I'll find that and I'll put a link in the description for everybody listening who's curious about that one. Right, when you're at your desk, what is your favorite snack?
Oh, I'm a big kid really, so I'm I quite like a few sweets on the go. Yeah, I don't know, wine gums or
Nice.
major jams or something just to munch on.
Nice, love it. When you're planning or organizing, so whether that's your PhD or the outline of a paper or like a report or things like that, are you a pen and paper person or are you a digital person?
Hmm. I mean, maybe a bit of both, but just keeping it simple. Yeah, so
Okay.
Word documents, tables, but you can't
Nice.
be a handwritten to-do list on your desk. Yeah.
I
I tick it
love
enough.
a to-do
Yeah.
list. Um, right. What book are you currently reading?
Non-research related or research
No, no,
related.
no, no. It
Yeah.
doesn't have to be.
Um,
Just any book that you're currently reading.
I've currently got by my bedside a book. My partner's recently been to Japan and he recommended it. It's called Convenience Store Woman. I think it's by Sayaka Murata. I think that's their name. It's quite a quirky little novel, but I think what's great is it's just really it's quite simply written. And I just find that I've got no brain power at the end of the day, so I need something easy.
Nice, I love it. When I was doing similar, I categorized my books, and I would only
Mm,
read when I was doing my PhD. I would read what I class as brain candy. So really simple, really easy, fun and smiley, nothing too
yeah.
hard or heavy.
Absolutely.
Right, last question is who is a researcher who you admire?
Gosh, there's lots of people. I think I know it's a bit corny to maybe to name one of your supervisors, but I think my supervisor and the team she work on are doing a really incredible project at the moment that to me is really inspiring. So my supervisor is Professor Els Guthrie, and one thing she does is she designs and trials treatments, psychological
Hmm.
treatments, usually for people who don't normally get to access
Okay.
those types of treatments.
Ooh.
And I think that's great because obviously, as psychological therapists, we want to be able to help as many people as possible, but sometimes services aren't designed in a way that make that possible. So
Mhm.
she's currently involved in leading the Fresh Start trial at University of Leeds. And that's about designing and then testing psychological therapies for people who present to hospital with repeated attempts at self-harm. So
Okay.
a group of people who don't often get offered therapy because services are worried that maybe they're too risky. And she's
Right.
deliberately, her and the team are looking at trying to design therapies that can be delivered in
Right.
existing services. So I think that's really great to think about groups of people
Yeah.
who don't get treatment for various reasons and trying to do something about that. So to me, that's great. And I guess coming on to my research interest later, I think it's interesting to think about groups that have been neglected. Yeah.
100%. I couldn't agree more
Mhm,
with you.
mhm,
Right. Well, that's the Rapid 11.
mhm.
Thank you very much. It's another one for the tea win. I'm trying to get more tea people because I'm a tea person myself. So I'm
Mhm,
like
mhm,
that question. I'm like, come
mhm.
on.
Yeah.
Right. So we got to know you a little bit better. We know you're an OT. We know you're a psychotherapist. We know what book you're reading. But can you tell us about how you ended up on an NIHR fellowship doing your PhD?
So I think I've had maybe a slightly longer, a rather windy, windy journey than maybe some other fellows. It's not something that I thought when I started out as an occupational therapist, which is, gosh, 25 years ago now, that 25 years later I'll be doing my PhD. So there wasn't maybe always a clear plan. But I think as I'd worked in my clinical area, which is in the field of liaison psychiatry, I suppose just started to be more interested in that field, had questions about that, that I think just grew slowly over time, really. Um, and then doing my dissertation for my master's degree
Mhm.
just gave me a taster, and I thought, oh, this is quite good. I quite enjoy this, but wasn't sure how I was going to be able to carve out any time. Um,
Mm.
I'd always thought a PhD would be nice, but didn't think about how I'd find the time to do that.
Mhm.
How is that going to be possible? And then the NIHR launched the pre-doctoral clinical academic fellowships back in 2018. And I thought, oh, that would be a great opportunity for me. And I was fortunate to get one, and that then paved the way to apply for a doctoral fellowship.
Oh, nice. So just getting a taster, doing your master's, and then I'm guessing that likely moving on into what you're now researching, that came from your work as an occupational therapist, or was that totally different?
No, absolutely from my clinical work. So I've been working in my clinical area for about, oh gosh, about 20 years by this point. So really familiar with the work, wanting something different, but wanting to, I guess, pick apart some of the things that our team was doing
Okay.
as occupational therapists, but also I'm really interested in how multidisciplinary teams work together in
Okay.
rehabilitation.
Okay.
Unpacking the black box of
Okay.
what does rehabilitation look like, and I guess that's where, yeah, my research ideas come from.
Okay. And are you happy to share that clinical area just so we kind of
Yeah.
get a bit of a picture of
Mm.
where you're operating?
Yeah. So within Liaison Psychiatry, one of the sort of patient groups that I have been working with and really enjoy working with are people with what we call persistent physical symptoms,
Okay.
which might sound like an unfamiliar phrase or could mean lots of things. So let me describe what we mean by that. So persistent physical symptoms means a range of physical symptoms that people can have, such as symptoms like pain or
Okay.
fatigue or weakness
Okay.
or a range of symptoms that aren't wholly explained by organic disease or biopathology.
Okay.
Um,
Okay.
so in the past, they were called medically unexplained symptoms, but
Okay.
then we've sort of seen we're probably moving away from that label now.
Okay. So people who, despite loads of investigations, despite testing, potentially other diagnoses, their diagnosis is physical symptoms that we can't find a reason for,
Yeah, or we can't find a full reason for.
or a
So
full reason.
yeah,
Okay.
they reckon so people
Okay.
might have a diagnosis, a physical diagnosis, but that maybe doesn't fully explain their symptoms. That's often the
Okay.
case. But yeah, so where it's felt that the symptoms maybe don't, yeah, aren't fully explained by existing illness that they have.
Okay. And so your job as an occupational therapist with these people um, is to do.
Well, so I think what's really interesting about occupational therapists, so I guess OTs in general, we have a focus on people's functioning and on
Mhm.
how we can support them in engaging in daily activities or occupations, as we call them, that are meaningful to them.
Yeah.
That would be the focus for any OT, would be to start at that point, of thinking about, how is this person's illness or symptoms impacting on their daily life, and how can we help them get back to those important things. Um, and that's really interesting, I think, particularly
Mm.
interesting in people with persistent physical symptoms.
Mm.
And that's because um, people with these symptoms, can be very disabled. I mean, and one thing that's really important to say is that the symptoms are very real.
Mm.
And I think that unfortunately, people have experiences of being disbelieved by
Mm.
doctors and other healthcare professionals, and people thinking, that maybe because tests are coming back negative, that means that they're not ill or they're not making up, they're making it up or something like
Yeah.
that, which they're very much not. And so people can be really disabled by these symptoms and have a real impact on their quality of life.
Yeah.
So what I think is really interesting as occupational therapists is, rather than getting into um, maybe debates and discussions about what might be causing the symptoms, well,
Mhm.
other people do that. We'll let the medics do that. Uh, but because those discussions can sometimes be helpful, sometimes not.
Mm.
And I think as occupational therapists, we can change the focus and we can say, well,
Yeah.
regardless of what's causing these symptoms, how can we work
Yeah.
together to try and help you do the things that are important to you? And that to me has always felt like a helpful approach.
Yeah. So a real collaborative approach to possibly coming up with ways to manage or alleviate
Mhm,
their physical symptoms that are persistent or
mhm,
unrelenting that won't go away,
mhm,
so that
mhm.
they're then more able and willing to do those things that matter to them. Okay.
Yeah, or help them find new ways to do the things that matter to them.
Okay.
Yeah, or help to change the environment so that maybe it's easier for them to do those things
Okay.
that are important.
I really like that idea of that real personal
Mm,
approach,
mm,
and like you said, like focusing on where you're at and not worrying so much about the where and the why fors,
mm,
and
mm,
just focusing on trying to get them to. Okay, so that helps.
mm, mm,
Thank you for clearing that
mm,
out, because I
mm,
think that's really important now that we start talking about, now that we understand what it is that you do.
mm,
What then are you researching in your
mm.
PhD?
Yeah, yeah.
What's your research question
Yeah.
3 years
So,
in?
oh gosh. So, what I'm really interested in is how can we best help people with persistent physical symptoms to engage in activities that are meaningful to them and participate in the world around them. So, my research question is
Okay.
how can we support people to improve their activity and participation?
Okay.
That's the research question, and I think that came because there are some occupational therapists working in specialist services for people with
Hmm.
persistent physical symptoms, but actually most people with these symptoms are seen in other services, so they're seen wherever they
Okay.
present. So by their
Okay.
GP, or they might, if their symptoms are looking neurological, they might end up in neural rehab services, or if it's mainly pain, they might end up in rheumatology. So they'll see occupational therapists, but for those OTs, there's no guidance about what they should be doing. So,
Okay.
so the research in this for people with persistent physical symptoms is mainly around psychological therapy, and
Okay.
mainly,
Okay.
um, and but I guess psychological therapies have only been shown to have a small or moderate effect.
Yeah.
And actually, for some people, that doesn't feel like the most appropriate treatment. Sometimes it isn't
Okay.
the most appropriate treatment.
Yeah.
And I've always believed that a multidisciplinary approach is where we need to go. And yet, for the OTs working within those multidisciplinary teams, there's no guidance. So my PhD
Ah.
is attempting to try and address that.
Okay. So you're wanting to help this
Mm,
population,
mm,
and you think to help this population,
mm.
it's better to look at the systems that are around that healthcare interaction. Who are the people that are around? Who are those resources? Where are those OTs? Who can those OTs liaise with in order to make sure that together the team builds a more appropriate.
I think in the longer term, I'm interested in that, in how the OTs can work with the rest of the multidisciplinary team, and I think that's vital. It can't be done in isolation at all. But I think but we're several steps before that, in that we don't
Okay.
even know what the OT should do themselves
Oh,
when
wow.
the patient's in
Okay.
front of them. No one's well, there are
Okay.
a few bits of work that have been done that I can mention, but overall, for the wider group of people with persistent physical symptoms, there's nothing really written about what occupational therapists um, should be
Oh,
doing. So we're
okay.
starting at the point of designing an intervention. That's the PhD.
Okay. Okay.
And then later on, we'd probably be thinking about how feasible is that? How can it be delivered?
Okay.
And in what context? Yeah.
Okay. I'm with you now. Just trying to get all the pieces put together and make sure that we get everybody else on the same page as well. Because I think like from the conversation we've had so far today and other conversations we've had privately, I think the thing that I really like about your research is you're really diving into this population that's underserved. We don't know much about them. We don't know much how to help them. And you're starting from scratch. So I think it's important to make sure that everybody who's listening to this episode understands all of that context. So now that we know what you're trying to do, how tell us about your research methods. How are you going about building this foundation, which hopefully might lead to a more informed um, intervention for OTs, regardless of which department they're working on when they come across these
Yeah.
individuals?
Yeah. So what we're recognising is there are perhaps a small number, but there are a group of OTs who are working in specialist persistent physical symptom services around
Okay.
the country, and within their practice, they've developed, within their day-to-day jobs, they've developed a treatment approach, which there's some observational data that treatment approach in the middle of a multidisciplinary team approach
Hmm.
can produce benefits,
Okay.
but it's not been described what that looks like.
Ah,
Um,
okay.
So my PhD is the biggest chunk of the PhD is a focused ethnography, where I'm visiting.
Oops, say that one more time.
Focused ethnography.
Okay, focus
Yeah,
ethnography.
yeah,
Keep going.
yeah.
We'll come back to what that is.
Yeah, I'll come back to what it is. So I'm going to be visiting 3 different specialist persistent physical symptoms teams, spending time with the whole teams, but particularly the occupational therapists, and finding out what it is that they're doing to observe that treatment and to talk to the therapists and the patients or service users about that treatment, what they liked about it, what they think could be improved as a starting point.
Okay, so 3 different centers. What is focused ethnography? And before you started your PhD, did you have any clue what it was?
I mean, I knew the word ethnography. I knew I had read a little bit about ethnography, so kind of knowing that that's about immersing yourself in a culture, understanding the culture and the behaviours of people in that group. So I mean, that was probably all I knew really. So I was introduced to the idea of a focused ethnography, so a more time limited, usually practical ethnography, where you're focused around a specific research question. You're looking to collect information about to answer your question. So it's usually your observations are more focused. You're trying to get distracted by interesting tangents and to focus on getting the information you need to answer your research question.
Okay, so that's I now understand it. Thank you. So you've got ethics, you've been out, and you've given this a go now, yeah?
Yeah, so I've completed the observations at the first 2 sites and just starting at the 3rd site. Hopefully, well, at the moment, yeah.
Congratulations. So I'm dying to know, because in my PhD, I haven't done, and I've read ethnography studies before, and I've read fascinating ethnography books, but I've never done it myself. So what was that like?
Yeah, so it's a really strange experience. I mean, obviously, I'm very new to this, and I'm fortunate that I'm supervised by some experienced ethnographers. But I think it was just strange, first of all, I think. So you kind of are arriving somewhere, obviously you've got the approvals beforehand and you've been introduced to the study, but still ultimately you're arriving into a hospital setting for the first ones, introducing yourself to people as a researcher, which again for me is strange. I'm used to being a clinician, and therefore introducing myself as a researcher feels somewhat strange. And then just starting to watch what happens. So it's been interesting. I think it's been tricky because obviously observing in a hospital, we've got to get consent from people. So I had a very particular approach to obtaining consent, which meant that it took a while before I could start observing actual treatment sessions. But then once we'd obtained that consent, someone would be having an occupational therapy session or a physiotherapy session, and I'd be sitting in the corner trying to be a little bit trying not to be too obtrusive. I might have a little notebook, I might not, and I'm just jotting down what's happening.
So this is going to be my next question, is in focused ethnography, how do you get data?
So I think in some ways it's the same way as you would in, I understand, as in traditional ethnography, in that you're observing what you're observing. You're making some jottings usually at the time, and then you're going away and you're writing up field notes for what you've observed. Yeah.
So pen and paper. And like just whatever you see as like little things, and then you go when you're done your session. So patient A, Mary, Fred, whoever it is, has kindly given you consent to observe this session. You go in, you observe this session quietly. You're not allowed to say anything. You just sit there.
Well, I mean, I can say something. I think it's about recognizing, that we're humans, aren't we? And we bring ourselves to our research. So I certainly wasn't wanting to be the faceless observer in the corner. So I think for me, it was always a balance between not interfering with what was going on, because obviously the therapists sometimes, are going to feel socially anxious, but they're aware they're being observed. So trying not to get in the way, but at the same time trying to be trying to be me, trying to be hopefully warm and interested, and not just sitting silently in the corner. So a balance between the two.
Yeah, you don't want to be like that hotel inspector that everybody's
For.
like, who's that weirdo in the corner?
Yeah,
But
absolutely.
but at the same time, I can only imagine how tricky it must have been to, especially you are a clinician, there were likely episodes where you're like, ah. Did you ever did you have to write about that in ethics? Like if, you're observing a situation and an emergency crops up, were you allowed then to step into the scene if you had those skills, or was it always you still had to, is it the insider outsider? Like, were you somewhere in between? Like, how does that work?
I think the things for us that when we were writing the protocol for ethics was that we weren't worried about emergency situations because
I just use that as an example because I couldn't think of a better one. Like a situation arises where you as a clinician wanted to say,
yeah. So I think what we'd talked about was that the only time that I wouldn't intervene in the session, but the only time I would maybe raise anything would be if I was concerned about, in the very unlikely situation that I'd be concerned about, seeing any malpractice. So was actually where we set the threshold. If I was worried some harm was being done, then there was a process that I would follow to address that. The same if there was some risk that came up that I needed to take some action, but that would never involve me intervening. And that's different to some ethnographies, where people do ethnographies in A&E and things like that, where they're how much do you intervene? But for me, slower pace of treatment. Not a need for me to jump up from my chair and take any action.
So I'm guessing then, because you talked about a complicated consent process, you'd have to get the consent of both of the clinician who you were observing as well as the patient.
Yeah.
Now, because you're also interested in like the MDT approach, was that a part of it at all? Like, did you ever have sessions where there was more than one clinician, or you'd go to MDT meetings, or how did that work? Or did you keep it limited to just clinician plus patient?
No, we wanted to see as much as possible that was relevant to treatment, and just thinking that the context was really important. So, occupational therapists, I suppose my belief is that they'll work best with this patient group when they're working as part of a multidisciplinary team. So I wanted to see that team at work, absolutely. So I've already been sitting in many multidisciplinary team discussions, ward rounds, huddles, various different versions of team meetings. But I think actually some of the most interesting discussions would happen in the office. Informally, and so I was able to, I would try and hang around the office as well, and people knew why I was there, and that's when some of the interesting discussions would also happen, and I'd be capturing those discussions as well.
Okay, so loads and loads of notebooks then.
Yeah. I've gone through 3 so far.
Whoa!
I mean, they're very little ones, but yeah.
But still, wow. So you finished data collection at 2 different sites.
That's right. Yeah.
So from the first site to the second site, did any of that strangeness reduce? Or was it still just really weird because it was the same all over again? Because that second site clinicians, you had to go through that getting to know you process again.
It's different. And I think, I guess without kind of wanting to reveal things about the sites, I think recognizing that my existing relationships with the people at the 2 sites was different. So my relationship with the first site was different to my relationship at the second site. So I think that was probably the reason for most of the differences.
In some ways.
So and I think in how much people already knew me, in what capacity they already knew me, was interesting.
That's fair enough and really interesting. So you're about to start on the third.
Yeah.
So Because this is a podcast, and because in addition to sharing your journey and talking about your research, we're also trying to make it so that it's usable for other people. So I know you've only done it twice and you're about to do it a third time, and you don't see yourself as an expert, but from my seat, you're much more of an expert in it than I am. So 2 sessions down into this specific methodology of method. Yeah, it's a method, not a methodology. Of focused ethnography. What would be your, like, if I was like, oh my goodness, Hilary, I really want to do this in my next study, what would be your top tips to somebody who's never done it before?
Yeah.
Yeah.
Well, I think the first tip, is probably a bit obvious, really. But I think get some supervision from an experienced ethnographer. So I'm very much a novice, so that was really crucial to get supervision from someone's experienced, because it is such a different way of looking at things. So some of the supervisors on my team, haven't done ethnography, and so it's been a really great sort of discussion to think about. Bringing an ethnographer in and saying, oh, this is how we collect the data. This might be the sort of data that we'll collect, and this is how we'll go about it. And the consent process will be different. And so that's the first, I guess, practical thing. And I guess, I think to give yourself time, which you will know anyway as a researcher that research takes time. But I think the times when I felt maybe slightly more rushed have been the times when you maybe don't collect data in the way that the way that maybe you might have anticipated. So but I think I would be really positive about it. I think in terms of a way of collecting information and the depth of the data that you collect. I've been asking my supervisors, is it rich enough? Is it in depth enough? I'm kind of worrying about it, they read some of the data, and they're like, yeah, this is the kind of data that you want to be collecting. So just encourage people to give it, I suppose, to consider it as an option, because it's not always considered. Most people, in health research that I meet, obviously now I meet more ethnographers because I look out for them, but it's not the usual technique that's used. Yeah.
No, I would agree. And I think it's one of the main reasons why, like, we reached out to each other ages ago for different reasons. And the more you shared with me your project and what you were planning on doing, the more interested I became, which is why I wanted to have this more public conversation about this method, because I think exactly like what you were just saying around the richness of the data for me from the outside looking and hearing about your experiences. You're capturing that, what a lot of people believe is uncapturable. So like that healthcare interaction and all the various components of a healthcare interaction, whether that's patient to clinician, whether that's medic to OT, OT to physio, physio to nurse, whatever those interactions are. And I don't know that in general we heavily consider those enough. So I read, and I had her on a previous episode, I'll put the link in the description, Professor Alison Pilnick, and she's a sociologist, and she's done a lot of ethnography. And her research and her book that she wrote around whether the arguing for or against patient-centered care or person-centered care and what the differences are, it was fascinating to me, because as a clinician, and I saw it in some of my research, but it wasn't the point, but as a clinician, you might have this conversation with somebody with nothing but the best intentions. And yet that person hears something very different to what you're saying. And because I listen to loads of podcasts, there's a podcaster that my husband listens to, and he actually shared that exact experience. He had an emergency, what he calls an ouchy tummy, a sore tummy ache. In reality, he needed major surgery, and there was a loop of his intestines that had gotten twisted and was black. But luckily, when they untwisted it, it was fine. and he was post-operatively, he asked the doctor, why did this happen? And the doctor was just like, oh, you were unlucky. And I know that clinician would have been like, you're fine, don't worry about it. There was nothing scary, there was no whatever. But he shared publicly on his podcast, he's like, oh, what does that mean?
Mm.
And it scared him. He's like, what happens if I'm unlucky again?
Mm.
I've already been unlucky because I've been shot in my service in the military. I've now had this. Like, what happens if I'm unlucky again? And it gave him a real level of uncertainty around his own health. And so I think like this as a method sounds like such a fascinating one.
Yeah, absolutely. Because I think, like that example of a clinical interaction, and that, afterwards, the healthcare professional would have had some, thoughts about that interaction, how it had gone, and the patient would have some ideas about how that had gone. But I think whether you would ever capture that in any other way, I mean, I'm sure there will be some methods that I don't know of, but it's, an interview, 3-6 months after the event would capture some of that, but not all of it. So what I found really interesting is to watch an interaction. It could be quite a simple, well, what would look simple, might look simple, interaction where, for example, an occupational therapist might be doing something, practicing a task with a patient, maybe in a kitchen or something like that, and they're doing this session. And then, well, what I find really interesting is then spending some time afterwards with the therapist and then the patient separately, and asking them about that session. So being able to say to the therapist, well, yeah, absolutely. So speaking to the therapist and saying, well, I noticed you did that. Why is it you did that? Why is it that you phrased it like that? But then also catching the patient separately, either straight after or later if they want some time to reflect and say, how was that session yesterday? What was helpful? What was less helpful? And then doing that repeatedly in different sessions. And I guess the thing that I have really been thinking about with ethnography in general is just thinking about how it's, the real focus on the relationship building, that you're in the field as it is for a period of time. Now, for focused ethnography, it's not the traditional, 6 months a year like you would be. For me, it's been, a period of weeks, rather than, large numbers of months or years. But that within that, you still build a relationship. And I've talked to the patients towards the end of the study and said, how was this? How was this to have me around, and how was it to have these chats? And I think they were saying that there was something about them getting to know me. And when we had the interview then at the end, so we do ethnographic interviewing towards the end of a focused ethnography, and then we're having an in-depth and recorded conversation about the treatment. I feel, now I don't know because I've not done a direct comparison, but I feel like the information I got from that interview and the things that people were able to talk about and share with me was because of the time that I spent with them. And when I've done interviews before, yes, you can get depth of data, but I just felt like I could ask them, they'd say something and I'd say, oh, that reminds me of that session you had with, this, that, and they would say, yes, it's just like that. Or no, you're not right, Hilary, it's not quite like that. And it would allow you to pick things apart, I think. So something about that, obviously it's focused, but you're trying to have some level of immersion. You're building relationships with those people in that setting, and you're building a much more comprehensive understanding of what's going on.
That's fascinating. Oh my word, so exciting. Thank you so much for sharing about this. So we've talked about why it's so good. Are there any reasons why you shouldn't?
I mean, I know, I was fortunate, and I think this was down to good supervision, but, so my process for ethics was reasonably smooth. Well, very smooth, actually. But I think obviously it can be, depending on you, if you're a health researcher, depending on your clinical area, you may come across some situations that could be quite could be tricky in terms of working out. And I know some people haven't always got ethnographies, approved because of some of those concerns. So I think just kind of, going into that with your your eyes a little bit open about how tricky that might be. And I guess there's something about, if someone who wants, volume of participants, you're not going to get that in ethnography. We're looking at, following a small number of people through over a period of time, and creating a lot of data about, or collecting lots of data about a smaller number of participants.
So in the end, your 3 sites, how many participants are you going to be hoping to have
Mm.
by the time you're done?
Yeah. So still to an extent it will depend, as it always does, doesn't it?
So how many do you have so far?
So far I've followed the treatment of 10 patients, and we've had about 20 staff involved. So because in
That's
hospitals
not
there's lots of staff
little.
around, and then so I'm aiming for at least in total at least 16 patient participants in total. Yeah.
Wow, that's not little, Hilary.
I mean, the amount of data I'm generating is quite large.
I was gonna say, so I know you haven't gotten into that yet, but my heart rate is going up thinking about like you've done most of this all pen and paper, and you've got recordings of your in-depth ethnography interviews. That's going to be a lot to get digitized, like, and how are you going to analyze it all?
Yeah.
And like,
Yeah.
and I know you might not be there yet, but already I have like a million questions.
Yeah. No, so I think one thing, very much encouraged to do is, yes, so whilst when I'm observing a session, I'm just jotting notes down. My aim was always the same day to expand on those, reflect on those, and type them up into a formal set of field notes. So that was done usually by the end of the same day, if not the next morning. Being good when it's all fresh. And the interviews have already been transcribed. So the data's already is already digitalized and sitting in NVivo. Yeah.
Oh, fascinating. So interesting. I'm trying to think if there was anything else I wanted to ask you, because I know it's such an interesting sort of group and an interesting piece of work that you're doing, and you're using like a really, I wouldn't go as far as unusual, but it's not that common, especially in PhDs. More people just do like an interview or a focus group or something like that. So I really appreciate you sharing your experience.
I think it was the more I sort of talked about it with my supervisors about this method when it was suggested very early on, actually in the planning, was that for this patient group it made a lot of sense. So I guess sort of thinking about people with persistent physical symptoms, my experience from talking to people, but the research says the same, is that they feel neglected by healthcare professionals, they feel disbelieved, distrusted, abandoned by healthcare professionals. So, how could I then, walk in and expect to get the information I needed from a one-off interview? I mean, we could have, I would have got some good stuff, but compared to, I think, the type of discussions I'm having with people now. So it's about building a relationship over time, and recognizing that obviously all interventions are complex, but one thing I'm finding is, that the treatment for this group is maybe particularly complex. So you're looking at conditions that aren't well understood, where there's a lot of heterogeneity in symptoms. It covers lots of different sort of subgroups of syndromes. It's generally acknowledged that it's a combination of biological and social and psychological factors that are involved. And the symptoms can vary so much from somebody who might be having, particular pain to someone who's having non-epileptic seizures. Obviously the treatment approaches, but those are very different. So much complexity, and therefore to spend the time with teams to pick it apart has felt really important way of starting to understand the complexity, alongside building some relationships with people where hopefully they feel able to share those experiences with me.
Wow. So cool. I might have to pester you again in another year's time to find out how you analyze it.
Yeah, that's going to be the test.
No, the whole reason why I want to do this podcast is I want to put spotlights on these different methods, on different health professionals that are doing research, because I think you gain so much more by hearing about people's journey and realizing that this sort of method is out there and feasible and doable, and like you said, like it could be a real match to a population that does feel underserved, that does feel neglected, because you would be able to build up a better relationship. So they're not just like, they don't just tell you about the thing that bothered them the most. They actually, because you've built that relationship, you start to unpick, whether it's from the patient point of view or the clinician point of view, those real important sticking points in this complex interaction.
Yeah,
So
absolutely. And I think it's really
fascinating.
interesting what settings you use. So my ethnography supervisor, Dr. Rachel Kelly, she uses ethnography to explore care for people with dementia. And I think that's really interesting. So people who can't, maybe would struggle to engage in
Yeah.
other more traditional research methods,
Yeah.
is using ethnography as a way of understanding and improving care. So I think that's really interesting, and that's we've had lots of interesting discussions about how we use ethnography with our own patient groups. Yeah.
Oh, fascinating. Right. Well, I think, because I don't want to encourage you or accidentally make you talk about what you think is going on, because you're still not there yet. You still have got one more site to go. So I think I'm going to wrap it up. It's a little bit, it's actually probably about a good time now. And just, I think before we go, the last question I'd like to ask you is, now, it might just be because I'm a nurse, so you have your own kind of bias of who you know, but there aren't that many people out there who do occupational therapy, and there's
Yeah.
even less people who do occupational therapy research.
Mm.
So, how and what would you say to
Mm.
any OT, whether they're in training, whether they're in practice, who's listening to this? Why should they consider research?
Yeah.
What's in it for them?
Yeah, yeah. So occupational therapy isn't that small a profession. There's quite a lot of us, but I would agree that not many occupational therapists are actively involved in research. And I think that's a real shame. And I think as occupational therapists, our evidence base for our profession is probably relatively underdeveloped compared to maybe some other interventions. And I know, certainly earlier on in my career, I would certainly, bemoan the fact that, why isn't occupational therapy in the NICE guidelines for this or for that? But because realistically, the evidence base, hasn't in many areas, not all areas, but in many areas hasn't been well enough developed. So I think, I firmly believe in the power of occupation and what occupational therapists can do. But we need to get out there and prove it. But how we do that is really daunting, isn't it? And I think that's why I thought, how do I do this? So I think for me, it's been about getting the key people involved. So whether that's from I suppose this is what I'd encourage OTs to do. So whether that's from within occupational therapy. So one of my other PhD supervisors is Professor Kate Radford, who's Professor of Rehabilitation at Nottingham, and she's an OT. And so, she's there's a great group of academic OTs in Nottingham. And so for me, it was about reaching out and sort of think about how they could support me. And even though Kate's area of research is with people who've had a stroke, actually, she understands about how you design and test rehab interventions. So that'd be one thing. Find the OTs. But the other tip I think would be to look broader than occupational therapy. Because you might think, oh well, there's no OT academic in my, in my part, my area. Well, let's think more broadly. So my primary supervisor, I mentioned before, Professor Guthrie, she's not an OT. She's a psychiatrist by background, but knows how to test interventions. So for me, it was about bringing those people together, and they've been amazingly encouraging. Once I reached out, and I think as OTs, sometimes we can sit in our clinical world and not reach out, and sometimes, focus on the things that are getting in the way. But and certainly things like NIHR fellowships, they're very keen to encourage underrepresented professionals, or professions rather. So I think therefore it stands in your favour that you're from occupational therapy when you're going for fellowships. So I think and we don't tend to. I think the statistics show from the each round, OTs don't apply in well, they apply in very small numbers.
Oh, Thank you. That I think is really good advice to everybody out there who's listening, who's research curious or is thinking about even becoming research curious. Is I think it's the message I'm hearing across lots of different disciplines is just ask.
Yeah. Yeah.
You might regret it at some point, 3 years into your PhD, but you won't by the time you're done.
No, absolutely. And I think when you were just, I was just purely clinician for 20 years, and I think, I wouldn't have necessarily thought about, or I might have been nervous about reaching out to academics. It's Holiday of the Ivory Tower, and we're down here on the ground doing the work, clinical work, and but actually, everyone I've approached has been just incredibly encouraging. So I'd encourage people to do that. Yeah.
Nice. Perfect. Excellent. And I think with that, we're going to call it for today. I know you're busy. I know you've got your PhD to do, but I might pester you again in another year to find out. Just actually one last question before you run, or before I let you run, I should say, because I've got you captive at the minute, is how are you going to be disseminating or sharing the results of this research?
Yeah, so there is a plan to share, but I think I'm also being aware that the output of the PhD will be a treatment manual and some training materials. But I'm kind of also really aware that at this point we haven't tested effectiveness, so we can't say it works. So I guess the dissemination plans will be taking that into account really. So we're going to be thinking about how we share that with occupational therapists through our professional bodies, through our local networks, but kind of with the wider groups that work in this field. And I think also to the patient groups as well. So I've got a wonderful group, a patient involvement group. We just met yesterday. They're a great group of people who have experienced persistent physical symptoms, and I want their advice as well on how we share that to get some of the results out to people with PPS as well.
Nice, I like it. And publishing?
Oh, absolutely, yes, no, yes. Almost goes without saying for a budding PhD student, I have to publish. Yeah, so we've got
well,
some
no, because the reason why I was asking the question is I know like some methods don't lend themselves to like writing a 3,000 word article, and to me, from the amount of and depth and richness of your data, the idea of trying to squeeze that into 3,000 words, so it was more like, is that going to be articles, or is it going to be a book or like a monograph, or do you not know yet?
I think at the moment, I guess the plan would be a series of articles. And hopefully, we're just discussing it today, one of those will be a bit more of a traditional ethnographic write-up. That would be nice.
What does that look like?
Well, I guess sort of thinking that I guess the word ethnography means that to write. So I think something that kind of is focusing more on the themes and being more analytical about what I've seen, whereas there'll also be a practical side about how the intervention is being planned and what the treatment manual consists of. So wanting a balance between having those a treatment manual and, like I said, some training materials as well, but also some written pieces to, I guess, to practice my writing as well. So
and to add to the evidence.
Yes, absolutely. Yeah, no, it's very clear we'll publish it, and NIHR are very keen on that, and so it'll be open access and all the usual things.
Very good, excellent. Oh, I could keep talking to you forever. The more I talk, the more questions I have. Thank you so much for your time, Hilary, and thank you so much for sharing your journey. And I know, like you said, you're not technically an expert
yet. Not an expert
yet. Because you're developing into one, but thank you so much for sharing about your really unique way of collecting data using this method that you're using and your experiences around that. I really appreciate that. I know that everybody out there listening is going to really find this valuable.
Yeah. Oh, that's great. I've enjoyed talking to you. Thanks, Rosalind.
Likewise. I'll talk to you later. Bye.
Okay. Bye.
Don't go away. Up next, we have the top 3 takeaways from this week's podcast by Dr. Rosalind Austin. I don't know about you, but I always thought ethnography meant, you had to become a part of that community, that you had to be in that community for at least 6 months, if not years. So it was very interesting to find out that it's actually also a method that you can use in really short periods of time. And even though it's a short period of time, that it can still reveal a lot more complexity and a lot more depth than what you might get in a traditional interview. So I found that really fascinating. I hope that really helps everybody out there who's trying to learn a little bit more about lots of different research methods. Right, top takeaways from my conversation with Hilary. The first one is that it's not too late. I loved how she was willing to share that, she'd been a clinician for loads and loads of years. She'd been, working as an OT and a psychotherapist for at least 20 years, I think she said, if not 22, not sure. And that it was at that point that she then started to pursue and develop her skills around research. So I really liked that it isn't something you have to do from, straight out of school. You can garner some experience about you, get some confidence, and then dive into research. So that was a good little top tip. The second top tip that I have from her chat is to try different research methods. And I thought, it's really interesting because so many people, when they're doing a PhD, you do a survey, maybe you do a pilot RCT, you do some interviews, some focus groups. Like there's typical sort of common methods that get used. And I really liked how she was like, no, that's not for me. I want to do this deep dive. I want to try this focused ethnography. And so she gathered the right people around her and she gave herself, built the amount of time that she'd need to do that into her PhD so that she could use this, what she felt would be a more appropriate and a more powerful tool to represent this population that she's trying to build some evidence around. So I thought that was really, really interesting. Right. Third takeaway is kind of following on from that, but is to become a part of building the evidence base. This whole podcast is all about research, and we have people, health research, and we have people from, pre-PhD doing some master's work all the way up to professors. And I think, I'm kind of speaking to the choir because everybody who I speak to is very passionate about research. But I think it's really interesting that when I asked her about why should people do it, she raised straight away that in her clinical field, her primary clinical field being occupational therapy or OTs, she talked about how that evidence base is lacking. It's not great, and it's not just OTs that's in. It's also like nursing has got a bit of that. I'm sure there's other professions, healthcare professionals out there as well that would say the same. And it's never going to change. We're never going to be able to actually do evidence-based practice unless people put their hands up and start creating that evidence. So I thought her general call to occupational therapists out there should be applied to everybody. And, if you're curious about research and if you're unhappy about the evidence that you're faced with as a professional, then think about switching and starting to help build the evidence base. That's it for me. I hope you guys enjoyed it. It was a little bit of a different focus today because it was much more about a specific method. Let me know what you think in the comments. Remember to like and subscribe as well, either here on YouTube or on your podcasting platform of choice. However you're listening to this, make sure to subscribe and like it. It just helps the algorithm. It get pushed up the algorithm more, so more people are able to find it. If you have any specific questions, I forgot to say this in the episode, if you have any specific questions to Hilary or about the method that she's using, do use the YouTube comment section in order to make it easier for me to find them and make sure that they get an answer. So yeah, any direct questions, please leave them below. Thank you so much for listening, and I will see you all again in another 3 weeks. Until then, remember to keep asking why.